This week, we would like to welcome Professor Emma Pierson to DBMI Seminar. Emma Pierson is an assistant professor of computer science at the Jacobs Technion-Cornell Institute of Cornell Tech and the Technion, and a computer science field member at Cornell University. She holds a secondary joint appointment as an assistant professor of population health sciences at Weill Cornell Medical College. She develops data science and machine learning methods to study inequality in healthcare. Her work has been recognized by Best Paper, Poster, and Talk Awards, an NSF CAREER Award, a Rhodes Scholarship, Hertz Fellowship, Rising Star in EECS, MIT Tech Review 35 Innovators Under 35, and Forbes 30 Under 30 in Science. Her research has been published at venues including ICML, KDD, WWW, Nature, Nature Medicine, and she's also written for the New York Times, FiveThirtyEight, Wired, and various other publications. And so with that, I will hand it over to Professor Pierson. She's requested that if there are any clarifying questions, feel free to raise your hand in Zoom and ask those throughout. And for larger conceptual questions, we'll save those towards the end. Alrighty, thank you so much. Take it away, Professor Pierson.
Sure. Thank you. Can you hear me okay? All right, I'll take that as a yes. So thanks so much for having me here. I'm actually very excited, very grateful to be here. I was at Columbia DBMI, as I was mentioning to the organizers a couple years ago, and it was a great visit. I really enjoyed it. In particular, I've always thought of this crowd as very thoughtful, not just about sort of the exciting things we can do with medical data, but also about its biases and limitations. And because of that, I'm very excited to get your feedback on some preliminary work. I actually rewrote this whole talk over the weekend, which means that the abstract is slightly inaccurate, but you know, and also that I'm somewhat nervous about presenting it. But I think your feedback and your comments will be really valuable. I'm going to be presenting some mature work at first, and then I'm going to present some more preliminary work, and excited to hear what you think. Okay, just to start with some motivation, as I suspect is known to you, healthcare and public health remain profoundly inequitable in the United States and worldwide. This is super well known, and I'm not going to sort of belabor the point now, right? And also familiar to you, I think, will be the fact that sometimes algorithms and AI have in fact exacerbated this inequity, right? And maybe exhibit A of this is a science paper from 2019 when a widely used algorithm used to predict health risk exhibited racial bias. Black patients with a given risk score were sicker than white patients with the same risk score. And this occurred basically because the algorithm was trained on a bad target, right? It was trained to predict cost as a proxy for health, and Black patients who had unequal access to care had less money spent on them than equivalently sick white patients. So algorithms on their own are no panacea to social and healthcare inequity, and in fact have exacerbated it at times. But my work has sort of pursued a more optimistic idea, which is that while this is certainly true, algorithmic and data science approaches can potentially reduce inequity in healthcare and public health if properly applied. And in particular, they can do so sort of through two general directions I've pursued in my work. The first is we can use machine learning to increase health equity by debiasing decision-making, both human and algorithmic. And I've looked at this in many contexts. I've looked at human biases in policing and in medical testing, and I'll be talking about that work today. I've looked at using algorithms to sort of detect human errors and bias in image analysis, and also to sort of improve risk prediction. So we can use sort of ML to sort of debias human and algorithmic decision-making. I think we can also use them to better understand the health of understudied populations, women, racial minorities, many other groups as well. And I've studied this in numerous contexts. I've looked at it in the case of COVID, in pain, in menstrual cycles. Obviously, you guys at Columbia have really pioneered some of the work on menstrual cycles, and also in the context of underreported conditions. And I'll be talking about that work today as well. Specifically today, I'm going to be telling you three stories. The first story is about policing and medical testing and detecting bias there. The second is about studying intimate partner violence. And the final story is about using race in clinical algorithms. And you might say, like, what do these stories have to do with each other? Like, is there any common theme, or are you just talking about random things? No, but there actually is a unifying technical theme. And the technical theme is this. And this is rare in my talks, by the way. Usually I just choose a bunch of like applications that are hopefully somewhat high impact and then try and claim. But like here, there actually is sort of a unifying methodological theme here. And that theme is missing data and its connections to health inequity. I think I've really sort of fallen in love with missing data as a problem, which is both technically challenging and very, very important to inequity in healthcare and public health. And it's sort of unfortunate that I've fallen in love with this problem because it turns out that missing data problems are really, really hard, as I suspect many of you know. So this talk is in some sense my cry for help. I've gotten obsessed with this problem and it's like very difficult. And so hopefully I can get helpful feedback on that. To dive in a little bit more detail about the outline of this talk, the first two stories are about human bias and its connection to missing data. I'll talk about human biases in policing and how that sort of manifests in patterns of under-testing or over-testing. And it turns out mathematically similar problems arise in medical testing as well. Then I'll talk about intimate partner violence and sort of human biases in terms of underdiagnosis and how that varies across groups in intimate partner violence. Then I'm going to talk more about algorithmic bias and how it relates to missing data. And specifically, I'm going to focus on quite a high-profile medical debate about when we should use race in clinical algorithms. And it turns out that there's a connection to missing data there as well. So let's jump right in. Let's start by talking about policing and medical testing. This work is sort of summarized in a series of like a couple of papers from me and many other authors, and you can find those citations below. So policing, is a public health issue. It is a major leading cause of death for young men in the United States, particularly for young African American and minority men. And today I'm going to be talking to you about police traffic stops. Why do we care about police traffic stops? Well, they're one of the most common ways that Americans interact with the police. Tens of millions of traffic stops occur every year. And, there's been concern that traffic stops may be racially discriminatory. And to be concrete, what I mean by racial discrimination in this context is this is when someone is treated more negatively because of their race. So they're stopped by police because they're Black. They wouldn't have been stopped had they been driving identically and they've been white. Or, they're searched by police because they're Black. They would not have been searched had they been behaving identically and they've been white. So this is obviously very bad if it's happening, but it is challenging to statistically test for a couple of reasons. And I'm going to talk about those now. The first is when we embarked upon this project, there was no national traffic stop data set. There was no data set that tracked every police stop that occurs in the United States, which might seem somewhat astonishing given how important this is. But, that's sort of the state of administrative records in the United States. So basically the way it works is that sort of every state and local police department tracked its own records separately in a different format. So step one on this project was actually to create such a data set, which, as you might imagine, is easier to say in a sentence than it actually is to do in practice. It took us about 5 years to do this. First, our journalist collaborators, really a bunch of rock star journalists, submitted data requests to more than 150 police departments over the course of 5 years. This was like a massive, massive effort on their part, and definitely a reason to work with journalists who are, about as good as it gets in terms of getting difficult to get data. Then all that data comes pouring in, right? And it comes in, in disks and hard drives and, whatever, PDFs and all kinds of like terrible data formats, right? And so basically we had to put in thousands of hours to sort of cleaning up that data. It's tens of thousands of lines of data processing code. But the good news is I'm not going to like summarize that, process for you because I'll traumatize myself. But the good news is that we've now made that data publicly available and you can simply download it online. So please use it in your own analyses. I think what I'm going to tell you about today really only scratches the surface of what is possible. And our main analysis, we have to focus on states that sort of have sufficient data for us even to do this analysis. For example, you can't analyze states if they don't track race data, which some states don't. And so our main analysis is on about 95 million police traffic stops. And in our analysis, we look at 3 questions. We look at whether the police discriminate in whom they stop. Second, we look at whether they discriminate in whom they search after a stop. And then finally, we look at how policy changes, specifically the legalization of marijuana, affect these racial disparities. Today, I'm only going to be telling you about the second question, and I'll be doing so because, it's an important question, and also because the methods are applicable to studying bias in many other decisions, as I'll describe, and they're also, as mentioned, quite linked to missing data. So, are police searches discriminatory? A little bit of background on police searches, just so you understand the setting here. So when the police stop a driver, they're allowed to conduct a search. The purpose of a search is to find contraband. So contraband here means things you're carrying that you're not legally allowed to carry. So illegal drugs, weapons, etc. And, the purpose of a search is to find contraband. It's not, the police can't do it just because they want to like harass a driver or, because they want to levy a fine or something like this. And because the purpose of a search is to find contraband, the way we define discrimination here is, are racial minorities searched when they are less likely to have contraband at a lower threshold of evidence. So if police search white drivers only if they're 10% likely to have contraband, but minority drivers if they're only 5% likely to have contraband, then that disparity in thresholds, that's discrimination under our definition. Importantly, this clearly doesn't cover all the bad things police could do during a traffic stops. It doesn't cover, for example, unlawful police use of force, for example. And that's one reason that we publicly released the data, because as mentioned, there are many analyses you could do. But clearly, this is one bad thing that police could be doing, and it is what we test for. And this is a missing data problem, right? Because the purpose of a search is to find contraband, right? But you only actually observe the outcome of the search for the people the police searched. In other words, if someone is searched, you observe whether the search found contraband. But if they're not searched, you don't know if they were carrying contraband and, if the police should have searched them. So another way of putting this is, you only observe outcome data for the searched population. So the outcome data is censored by human decision-making. And this is tough. That form of censoring is tough because, human decision-making might be imperfect. The police, of course, could be biased in whom they choose to search, but they also potentially have access to unobservables, factors that are relevant to whether someone is carrying contraband that are not visible in your data. All of these things mean that the unsearched population may be very different. You can't simply train a model on the population who was searched, the population with outcomes, and assume that it generalizes to the entire population. And I'll talk a bit more about this at the end of this section, but I will mention now that this is known as a selective labels problem. So a problem where sort of you only observe outcomes on some of the population in a way which is sort of censored by human decision-making it's been called a selective labels problem. Problems of this form appear in many high-stakes domains, in hiring and lending, recommender systems, medicine, they're very, very ubiquitous problems. And they've been studied for a long time by various fields, from epidemiology to econometrics to statistics to computer science. So this is an old problem. So how do we test for discrimination in searches? I'm going to tell you about a couple simple tests we can do here, and then I'll tell you why they're flawed, and I'll talk about the method we ultimately use. So first simple test might be, let's look at search rates, how likely different groups are to be searched. And when you do this, the disparities are immediate and striking and obvious. Minority drivers are much more likely to be searched after a stop than are white drivers. And I've shown those results at the right? Big gaps in search rates. But this by itself does not prove that the police are being discriminatory, right? It is possible that some race groups are more likely to be carrying contraband, weapons, drugs, etc. The purpose of a search is to find contraband. So if some groups are more likely to carry it, then the police may be more likely to search them simply in the course of normal police work, even in the absence of discrimination. So a second test which has been proposed is look at the outcomes of the searches. Don't look at how likely someone is to be searched. Look at how likely that search is to find contraband. So that's what we would call the hit rate of a search. And sort of the intuition here is like, look, if searches of white drivers are finding contraband 90% of the time, but searches of black drivers are finding contraband only 10% of the time, then that suggests that police are searching white drivers only if they're very, very likely to carry contraband, but they're searching black drivers more at random on the basis of less evidence. And so that's sort of evidence that they're sort of applying lower thresholds in their searches of black drivers, suggesting discrimination. So if hit rates are lower for minority drivers, then that is evidence of discrimination under the outcome test. And when we look at our data, that is in fact exactly what we see. Shown it right, the hit rates for Black and Hispanic drivers are lower than those for white drivers. So the outcome test too suggests discrimination. Turns out, though, that the outcome test also has a problem, and this is a somewhat subtle statistical issue known as infra-marginality. And I'm going to illustrate this for you with a purely hypothetical example. So this is entirely made up data. This is not our real data. This is hypothetical, right? Imagine there are only two races of drivers, white drivers and black drivers. And imagine among each group, there are two easily distinguishable groups. Like maybe one of them is wearing blue hats. There are the likely to carry contraband drivers and the unlikely to carry contraband drivers. Among the likely group, 50% of black drivers carry contraband, 75% of white drivers carry contraband. Among the unlikely group, 5% carry contraband, irrespective of race. And importantly, imagine in this hypothetical example that the police are not being discriminatory. They search everyone who is more than 10% likely to carry contraband. So what is going to happen to the hit rates for white and black drivers here? Well, the police, are going to search all the likely drivers, and they'll end up with a hit rate of 50% for black drivers, 75% for white drivers. So under the outcome test, it will look like there is discrimination, even though by hypothesis, in this purely hypothetical example, the police are applying equal thresholds. So, and importantly, the outcome test can also yield misleading results in the other direction, where it fails to find discrimination, even though in fact it is occurring. So why is this happening? What's happening basically is that the statistic we're measuring, the probability of carrying contraband, conditional on being above that search threshold, is not the same as what we care about, which is the threshold itself. These are just not the same quantity. That threshold itself is hard to measure. It's not a simple fraction, the way the hit rate or the search rate are. And so the solution that's been proposed is to use a Bayesian latent variable model to infer the threshold. And I'll tell you about that model. So the threshold test, as it's called, proposes a stylized model of a police stop. And the goal of this model is to estimate search thresholds that are consistent with the observed data, namely the search rates and the hit rates. So the search thresholds are like latent variables that you're trying to infer from the observed data. And discrimination under this model is if the police are applying lower search thresholds for minority drivers. So what is this stylized model? And of course, like all models, it's not intended to capture all aspects of the world, but it's intended to be realistic enough that you can kind of properly recover the quantities you seek to recover. Okay, here's how the threshold test models a police stop. It assumes that when the officer stops the driver, they estimate the probability P that that driver carries contraband. And P is drawn from a risk distribution. This is a probability distribution on the unit interval, so it ranges from 0 to 1. I've shown an example outright. So if, for example, the police pull over, a bus driver, it's probably quite unlikely that he's also carrying drugs, like he's carrying kids around, so P would be quite low. If, on the other hand, the police pull over a driver who is acting woozy and drinking out of a bottle, it's possible that that's some innocuous substance, but certainly P would be much higher, right? So P is sort of, the officer's estimate of the probability the person carries contraband on the basis of sort of all the observable and unobservable characteristics. And if P exceeds a threshold, the officer searches the person and finds contraband with probability P. So in the case of the bus driver, he'd be below the threshold and we wouldn't conduct the search. The police wouldn't conduct the search. In the case of the woozy acting driver, he would be above the threshold. The officer would search him and would have a 75% chance of finding contraband. And the model allows the thresholds and the risk distributions, so that blue curve and the black dotted line, to vary by race and location. And discrimination under this model is if the police apply lower thresholds in their searches of minority drivers. So again, if they search black drivers when they're only 5% likely to have contraband, but white drivers only if they're 20% likely to have contraband. In order to actually fit this model, you need to specify a mapping from basically those unobserved variables to the observed data. So to be concrete, the observed data are the search and hit rates for each race and location. And the unobserved variables are the thresholds and the parameters of the risk distributions. We have to sort of parameterize the risk distributions because if you try to infer arbitrary probability distributions, you sort of have infinite degrees of freedom, and you can't estimate that from the observed data. It turns out that the search rates and the hit rates have pretty nice mathematical forms in terms of the thresholds and the risk distributions. So that sort of specifies the mapping from the unobserved parameters to the observed data. To complete the Bayesian specification, you don't just need that likelihood model, you also need priors over your latent parameters. So we place priors on the thresholds and the risk distribution parameters, and then you can infer the posterior over the latent parameters using Hamiltonian Monte Carlo, which is a specific variant of MCMC. I will mention, since this is a talk at Columbia, that all of this was facilitated by the programming language Stan, which was developed by many folks at Columbia in collaboration with others. And I am a big Stan fan. I stand for Stan. I don't know. I may be dating myself. At any rate, yes, I think it's a great language. Okay, fine. Unfortunately, actually, all of this doesn't work on data of our size because if you try and use standard probability distributions, the quantities you need to compute are extremely slow. Computing, the requisite quantities using standard beta distributions is prohibitively slow. Not going to get into the mathematical details there now, but I will tell you the practical consequences, which are these. First, you can't fit a model on the entire massive national data set we've collected. And perhaps more importantly, the test can't be used by the people who really need it. Journalists, well-intentioned police departments, activists, whatever, right? It really limits the applicability of the test. So what we did was we invented a new family of probability distributions, which we termed discriminant distributions. That's not so called because of their connection to discrimination. It's actually called that because of its connection to latent discriminant analysis. And because they rely on normal distributions, it turns out that the requisite quantities are much faster to compute. And we can use them to create a fast threshold test that runs 100 times faster. So the basic point is we invent this new family of distributions, we use them to parameterize the risk distributions that makes the test run 2 orders of magnitude faster. And this is sort of a concrete illustration of how, like, doing intricate math can actually have practical consequences, because this means we can now run on our national data set, and also that sort of non-academic practitioners can more easily use the test. So with the fast threshold test, we're actually able to fit a national model, and the results of this are shown here. Basically, the model infers that thresholds are lower for Black and Hispanic drivers than they are for white drivers, suggesting discrimination under the threshold test. So just to summarize what I've shown you today, I've shown you 3 things, right? I've shown you search rates are higher for minorities, hit rates are lower, and thresholds are lower. And this is a characteristic pattern for discriminatory searches. You will see it, for example, if you apply these models to stop and frisk data, which is, whatever Mike Bloomberg might say, extremely obviously discriminatory policy. And in fact, of course, was found so by a federal judge in 2013. All 3 tests here in our data set are suggesting discrimination against minorities, but the threshold test is doing so in a way which is robust to the statistical flaws of simpler tests. Just to speak briefly about the public policy of the impact of this work, in 2019, the Los Angeles Times was able to take our fast threshold model with some help from our team and run it on data from Los Angeles to show that the LAPD was searching Black and Hispanic drivers on the basis of sort of lower thresholds. So exactly that same type of discrimination. And in response to that, this is why journalists are great, within a week, the police announced that they would dramatically cut back on pulling over random vehicles in response to these racial bias concerns the journalists had raised. So this is sort of why it was useful to broaden the set of practitioners who could actually apply these models. I want to sort of close, though, by talking about how problems of these forms appear much more broadly. Basically, you can apply the same methods in other data sets where you have a decision, and then, for the subset of the population where there's sort of a positive decision, you observe the outcome. So for example, in a lending context, the decision would be, does the bank give someone a loan? And the outcome would be, does the person repay the loan? And so discrimination under this might look like, minority applicants for loans are less likely to receive loans and more likely to repay them, conditional on receiving. In medical tests, the decision might be, does the doctor test someone? And the outcome is, does the person test positive, right? And so discrimination under this model might look like, minority patients are less likely to get tested and more likely to test positive when they do. And so this is sort of a very, very broad setting that methods like this are potentially applicable. Selective labels problems, in addition to being very broad, are important and unsolved. The threshold test is one way to attack them, but there are many other ways to attack it too, right? In general, these problems are unsolvable without assumptions, and the reason is without making assumptions, the untested population, so the people who aren't searched or aren't tested or didn't receive the loan, can have any distribution. It's possible that they all would have repaid their loan. It's possible that none of them would have repaid their loan, and without sort of more assumptions, you cannot discriminate between those two possibilities. And so my opinion here at the moment is that we probably want domain-specific solutions to this problem, because which assumptions are reasonable varies by domain. So in a policing context, the data are often extremely sparse, like, departments often don't have very detailed records. And so, you sort of need to make stricter parametric assumptions like the threshold test to allow you to get anything from relatively little data. In contrast, in medicine, you often have very detailed EHR data, and there may be better solutions than the threshold test. There may also be other sources of sort of side constraints, ways you can sort of place constraints on the possible distributions over the untested population Not going to talk about that in detail now because it's a problem I'm actively thinking about. But if this is something which is of interest to you, I'm super happy to chat more. I will just say, as a sneak preview, the idea of applying this in medicine is not hypothetical. I actually did this a year or two ago, and I took threshold test models and applied it to COVID testing data, basically to see, are minority patients being tested only at higher thresholds, only when they're more likely to have COVID. And indeed, that is exactly what the model found. Basically, Black and Hispanic patients were receiving these tests only at higher likelihoods of having COVID. And sort of that manifested in traditional statistics as like lower testing rates and higher positivity rates, conditional on being tested. But the threshold test is sort of a way to take that data and use it to infer the threshold. Okay. So that's the first story, selective labels, policing, its connections to medical testing. This is very, very much a problem of fascination for me and very much happy to chat more. Let's talk about the second story. This is a story about intimate partner violence. It is work led by Divya Shanmugam, who is an excellent PhD student at MIT. I will mention she will be on the job market, I think, in a couple years. You should definitely try to hire her. She is terrific, or alternately don't try to hire her so we can hire her at Cornell. But no, she's really wonderful and she's done great work here. Okay. So the goal of this project is to attempt to assess the relative prevalence of underreported conditions like intimate partner violence. What do I mean by the relative prevalence? That simply means how much more common is a disease in one group versus another. So here, I've shown for Black and Asian patients, and red shows the affected patients. And so you can see, 4 Black patients are affected, 6 Asian patients are affected. And so the relative prevalence would be 4/6. So it's just like how much more likely is a disease or medical condition to occur in one group versus another. And the challenge here that we seek to confront is, so obviously, like if the disease is perfectly observed, this is trivial to do. It's just a fraction, right? But if it's not perfectly observed, in particular, if there is underreporting and the underreporting varies by group, this becomes much more challenging, right? So here, imagine that this is the reported occurrence of the disease, right? And so it's reported in 2 Black patients, 1 Asian patient. And so if you just go from that observed data, then you're going to end up with an incorrect relative prevalence. So, inferring the relative prevalence in the presence of underreporting, which varies by group, becomes much more challenging. Why do we care about relative prevalence at all? Well, it's useful basically for quantifying disparities and passing policy to ameliorate them. And to give sort of a case study of this, in the 1990s, there were reports describing high relative prevalence of diabetes in Native Americans. They were 2.5 times more likely to have type 2 diabetes. And in response to that, in 1997, Congress established the Special Diabetes Program for Indians. And over the next sort of decade or so, there was a huge decrease in diabetes-related complications in this population. So why do we care about relative prevalence? Because identifying populations with high relative prevalence helps us sort of identify the populations who might benefit the most from targeted policy, and this is both more efficient and more equitable. Why do we care about underreported conditions? Because they're ubiquitous, right? Many important medical conditions are underreported in a way which varies across groups. The condition motivating this work is intimate partner violence. Both Divya and I prior to working on this project, read the book No Visible Bruises, which is about sort of how intimate partner violence is often invisible. That's true for this condition, of course, but it's true for many, many, many other conditions as well. And furthermore, the reporting rate varies across groups. So let's get a bit more formal about the model setup, how we're going to seek to sort of quantify this underreporting in a group varying way. The setting we're going to imagine we're in is what's called the positive and unlabeled, or PU setting. And this is sort of an old line of machine learning literature, but I'll just sort of explain it briefly so we're all on the same page. So PU learning assumes that you observe 2 types of patients: true positives, the people who really have the medical condition, and unlabeled patients. And those might consist of true positives and true negatives, right? So like your ideal world in machine learning, right, is you observe true positives, true negatives, you train a classifier to discriminate between true positives, true negatives. We know how to solve that problem. This is a harder problem because the unlabeled people consist of both true positives and true negatives. And this is widely used to model underdiagnosis, right? Because you might imagine that like, if a patient is really labeled with having a condition, then they have it. But if they're not labeled, you don't know if they don't have it, or they never saw the doctor, or the doctor didn't label them, or whatever, right? So it's widely used to model underdiagnosis. And there's an assumption here, of course, in this PU setting. The assumption is there are no false positives. In other words, if you're labeled with having a condition, then you truly do have it. But this is like very widely used as sort of a model for underdiagnosis in medicine. You might ask, okay, clearly this is a missing data setting, right? Because the unlabeled population consists of people who both have a disease and don't have a disease. So, by definition, there's sort of missing data there. So you might ask, how does the PU learning setting compare to the selective label setting that I showed you in the last section of the talk? Turns out PU learning is even harder than selective labels, and selective labels is already hard. Why is it harder? Because in selective labels, you observe three groups, right? You observe true positives, true negatives, and unlabeled. So in the medical testing context, the true positives are people who were tested, test positive. The true negatives are the people who are tested, test negative. And the people who are unlabeled are the people who didn't get a test. So there are three groups, right? In PU learning, though, you only observe two of these groups. You only observe the true positives and the unlabeled. So great. No, this is not good, right? PU learning is harder than a hard problem that we already don't know how to solve. So we're definitely going to have to make assumptions to make progress, right? To give a little more intuition for why you need assumptions in the PU setting, not just by comparison to another problem in which you need assumptions, let's say that you see that a disease is very rarely diagnosed. Without assumptions, you cannot tell the difference between two situations. This disease really is rare, and this disease is underdiagnosed. Like those situations, you cannot distinguish them on the basis of the data, right? So you need assumptions to make progress here. And so one frequently made assumption that PU learning methods make is that the positive and negative, the true positives and the true negatives are at least somewhat separable. So it looks sort of like the graph at right. In other words, there is a region of the feature space where there are only true positives. So like everyone in this space truly has the condition, it's just that only some of them are labeled with it. So if you're willing to make that assumption and you can identify the region of that space, then you can just look at the fraction of examples in that region of the space, which are labeled positive. So for example, if you're like, look, I know everyone in this region of covariate space truly has the condition, but only 30% of them are labeled, then you can say, okay, like the label frequency, the probability of being labeled conditional on having the condition, is 30%. And then these methods tend to make another strong assumption, which is that the label frequency remains constant across the whole space. In other words, everyone has a 30% chance of being labeled with a disease. And from that, you can sort of back out people's true probability of having a disease, the fraction of the population that have the disease, other things you care about. The problem is that like these assumptions don't seem all that plausible basically in medical settings. Like it's just not that believable that there's some region of patient space, some particular set of symptoms where like if people have these symptoms, like for sure that someone has the condition. And furthermore, that the rate of labeling of people in that region of the space generalizes to the rest of the population. So what we do here is first, we propose relative prevalence estimation as a novel PU learning task. So generally when people do PU learning, they don't focus on trying to get the relative prevalence. They focus on, we're going to try and actually estimate the absolute prevalence, so the absolute fraction of the population, which truly has a condition. And that turns out to be a harder task. We haven't seen a lot of work focusing on this particular problem, which is quite important in public health. We provide a set of assumptions under which you can recover the relative prevalence, and we think those assumptions are more plausible in medical settings than the separability assumption. And so as such, you can think of our work as sort of complementary to these other lines of work that make different assumptions. Everyone has to make assumptions to make any progress here. We provide a method for getting the relative prevalence if these assumptions hold. We provide checks on the assumptions so you can sort of get a sense of when they might not hold. And we also provide validation on several types of data, and I'll show that to you soon. I'm going to give you the math on our method in a second, but I want to start by just giving you the basic intuition. So just sort of in plain language. Let's say you want to know about the relative prevalence of intimate partner violence in Black patients as compared to white patients. But intimate partner violence is underdiagnosed and maybe in a varying way across races, so you can't just take the ratio of diagnosis rates. What you can do, though, is you can learn which symptoms are suspicious for intimate partner violence. You have a couple people who are really labeled with having this condition. They have like a gold standard diagnosis of IPV, and you can learn what other symptoms they attempt to have from those few labeled cases you have. Then, if you're willing to assume the suspicious symptom model is the same across races, then you can back out the relative prevalence. Roughly, the race group that has the higher prevalence of suspicious symptoms has the higher prevalence of intimate partner violence as well. So that's sort of the method. You learn a model of suspicious symptoms, and then you then apply that model in order to attempt to infer which groups have the higher relative prevalence. I'm going to introduce some notation to make that a little more formal. We assume that the unobserved true label, so this is what we really care about, but do not observe, is Y, and this is has a patient really experienced IPV. The observed data is three things. First, we have S. These are the observed labels, and this is basically has a patient been diagnosed with IPV. X is the observed features, so the patient's other symptoms. And G is the patient's group. So for example, their age or race or insurance status. G is the thing we care about, inferring relative prevalence over. Okay. And, we're going to make the P assumption, in other words, that there are no false positives. So, the probability that S equals 1 if Y equals 0 is 0. So you're never going to be labeled with having the disease if you don't have it. And this is pretty reasonable in our setting, by the way, because it's easy to define sort of a gold standard set of intimate partner violence codes that literally say this person has experienced this. Okay. So given that setting, how does the method work? Basically what we do is we model the probability that a patient is diagnosed with a condition given their groups and their symptoms. This term is fully observable from the data because we observe S, we observe X, we observe G. And we model it as the probability of two terms. First, the probability the patient truly has the disease given their symptoms. And second, the probability the patient is diagnosed given that they have the disease. And I'll tell you the assumptions in a second under which this is a reasonable decomposition. We assume that that first term remains constant across groups. So sort of your probability that you have the disease is the same given your symptoms, regardless of your group. We allow the second term, the group-specific reporting probability, to vary across groups to allow for underreporting. So from staring at this equation, you can notice that we can't estimate either of the terms on the right-hand side exactly, since we only observe their product. You can always multiply the first term by 2 and divide the other term by 2, and you'll get the same sort of prediction for the term on the left-hand side. But it turns out that even estimating probability of Y given X up to a multiplicative constant is sufficient to estimate the relative prevalence. So that's the method, basically. We first use this decomposition to estimate PY given X, and then we look at how PY given X varies across groups to estimate the relative prevalence. And that's what I'm showing you on this slide. Basically, you estimate PY given X up to a constant factor, and then you just take its average, you take the ratio of its average value across groups. And basically, even if PY given X is off by a factor of 2, that factor of 2 is going to cancel out. So this actually means that you can estimate the relative prevalence even in cases where you can't estimate the absolute prevalence. And that's sort of what we leverage. Now, all of this only works under 3 assumptions, which are pretty widely made and we think are pretty reasonable in this setting. Let's talk about what those are briefly. The first is, well, okay, I'll talk about each of them in turn. The first of them is the no false positives assumption. This is sort of made by every PU learning method. It won't always hold if sometimes people are falsely diagnosed with a condition when in fact they don't have it. The second condition is what we call random diagnosis within groups. In other words, conditional on truly having a disease, everyone within the group is equally likely to have it. This would not hold, for example, if people with particularly severe symptoms are more likely to be diagnosed with a condition, but it is nonetheless a common assumption in PU settings. Most models you would see would make this assumption. And the final assumption we make is that patients with the same symptom are equally likely to have the condition regardless of the group. So basically a constant PY given X across groups. And this is basically the assumption we make as opposed to the restrictive separability assumptions. Again, this won't necessarily always hold. You kind of, whenever you're in the PU learning setting, because the inference task is so challenging, you always have to make these sort of imperfect assumptions. But we believe that it is more plausible in the medical setting than are sort of these very restrictive assumptions that there's some magical region of the covariate space where everyone truly has the condition and you can find that, and then the label frequency there generalizes to everything else. Okay, so under these 3 assumptions, we show mathematically, does the method work? The method does work, but you might not believe the math, so we actually test on a bunch of different data sets to sort of show that it works. We start by looking at synthetic data. The purple dot at right shows our method. You want to be on the dotted line, which basically indicates that your inferred relative prevalence is the true relative prevalence. And you can see that while a bunch of the baselines work, in the left plot in the separable case. Our method is the only one that works on non-separable data, except for the green dot, which is basically an oracle. That's just sort of to give you an upper bound on performance, but you can't actually implement it in real data. Okay, but like you can show anything on synthetic data, right? So then we do a bunch of experiments on semi-synthetic data where we take real medical data and we choose 4 different sets of suspicious symptoms. And basically the reason we do this is so that we can assess how purple actually performs, how our method actually performs on real data, but where the true relative prevalence is known. And we continue to perform well in that setting. I think I'll only briefly talk about what happens if the model assumptions are wrong. Basically, even if sort of the major new assumption in our method, constant py given x, is wrong, we still provide a lower bound on the magnitude of disparities. So we can still say disparities are at least this big, as long as the group with higher prevalence also has the higher prevalence conditional on symptoms. And it's useful to provide a lower bound because if you say, we know that this group is at least this much more likely, you still might feel confident targeting policy towards that group. We also provide 2 other checks for violations of the model assumptions. You know, again, you have to make assumptions in the PU setting, but we enable you to rule out some cases where those assumptions clearly do not hold. Okay. We then apply the model to real data on intimate partner violence. We take data from MIMIC4, which is, you know, sort of a widely used data set to study medical issues. And we show basically in our initial analysis that the method finds higher relative prevalence among unmarried patients and Medicaid recipients. This is consistent with past work. We also find racial discrepancies that are consistent with past work, but they're somewhat smaller. That initial sample we look at is a bit weird. It consists only of people who both went to the ED for intimate partner violence and then were hospitalized, which is sort of an unusual sample that doesn't necessarily sort of represent the population you really care about. We then got several other samples. We got a subset of MIMIC where we actually have all the emergency department patients, not just those who were ultimately hospitalized. We also look at a data set called HCUP, which consists of 1.6 million emergency department visits from the state of Maryland. And in both of those data sets, you know, we sort of find consistent discrepancies across marital status and insurance. Discrepancies across racial groups are somewhat smaller and a little less inconsistent, but the discrepancies across insurance and marital status are quite consistent. This is work, by the way, assisted by William Howe, who's an undergrad at Hopkins, who has really done pretty excellent work on this and will be applying to grad school. So if you see his name in the pile, he's done great work. Okay. I think I'll skip over our application to hate speech, but basically, you know, we apply the method to sort of infer the relative prevalence of hate speech depending on what group it targets. And we find that hate speech is more likely to sort of target groups which face societal discrimination. For example, you know, transgender people face higher rates of hate speech. And also sort of when a method mentions, or sorry, when a comment mentions a minority group at all, it's more likely to be toxic. This application sort of showcases the applicability of the method beyond medicine to other settings of sort of, you know, public health, societal discrimination, et cetera. So to summarize this part of the talk, we propose relative prevalence estimation as a task in PU learning that really hasn't been considered that much so far or even at all. We show that relative prevalence estimation can be performed even when absolute prevalence estimation can't. We provide 3 assumptions under which you can recover the relative prevalence. Those assumptions are complementary to different assumptions in epidemiology and PU learning, which has been made before. We provide a method, purple, that leverages these assumptions to actually give you estimates. To ensure that the method is used responsibly, we provide assumption checks and robustness to a plausible violation of the assumptions, and we show results on synthetic and semi-synthetic data. In future work, you know, we think that this method is broadly applicable to settings where you care about the relative prevalence and you're willing to believe sort of the fairly widely used assumptions the model makes. We're very curious to hear other settings you might be interested in. To me, sort of the obvious application of this is long COVID, which is a wildly underdiagnosed condition with disparities across groups. But you know, we've considered other settings as well. I will briefly mention, you know, we've done a lot of other work on women's health as well. And I mentioned this only because, you know, I know there are a lot of folks at Columbia who care about women's health, menstrual health, et cetera, and very happy to talk more about that. If you're interested, feel free to shoot me an email. Okay. Let's talk about the final story. Let's talk about algorithmic bias. This is joint work led by Anna Zink, Ziad Obermeyer, and Anna is a postdoc at U Chicago. Ziad is a professor at UC Berkeley. And this is like extremely preliminary work. It did not have a title prior to about 3 hours ago. And so your commentary is very welcome. Okay. So as many of you know, there's been a high profile debate in the medical community around use of race in clinical outcomes. And this is not just a debate which is happening in like the Lancet and the New England Journal of Medicine. It's also a debate with immediate implications for patient care. So for example, senators are requesting more information about this. Hospitals are changing the way they compute various things, right? And so like, patient lives are actually on the line, depending on the consequences and the sort of outcome of this debate. To give a concrete example, probably the most widely discussed example is in computations of what's called eGFR, which is a measure of kidney function, right? And I've shown you on the left a screenshot from MD-Calc, which is a tool that is used by clinicians to compute various medical quantities. And you can see that MD-Calc basically has an option for whether or not you use a patient's race, specifically whether or not the patient is Black, in your computation of eGFR. And, if you change whether or not you use this coefficient, it changes the way you compute eGFR for patients. That has a bunch of downstream implications, like whether the person is diagnosed with kidney disease, drug dosing, transplants, donations. So like, whether or not you use race affects how you compute this thing, affects a whole bunch of downstream outcomes. So that's one example in nephrology, but like this same debate is occurring across many domains. And broadly, the scrutiny is very good. It's vital and it's overdue. There are a bunch of reasons we should be worried about the use of race in clinical medicine. These reasons include some of these race corrections have been based on extremely dubious empirical data, small, non-representative samples done in like the 1940s, right? So like that on its own should make you worried. We might have concerns about exacerbating health disparities. If you use race in a clinical algorithm and it rates minority patients as lower risk, for example, maybe they get fewer screens. This can, contribute to disparities in underscreening. And of course, there is a long, very bad history of racist beliefs about biological racial differences that did not exist, right? Racial differences in how different groups perceive pain, which has led to undertreatment of pain in Black patients, racial differences, beliefs about racial differences among radiologists that like Black patients needed higher doses in X-ray machines. Like, yeah, you can imagine why that was very bad, right? So there's a long, bad history of racist beliefs here. So all of these reasons mean that the scrutiny is vital and overdue. At the same time, there's some reason for caution, right? Removing predictors in clinical algorithms that have life or death consequences is something you want to do carefully. And here's a sort of opinion piece in the New England Journal of Medicine in which a bunch of doctors basically say, please, be careful removing race from clinical algorithms and treatment guidelines. So there's reason for concern. There's also reason for caution. And our contribution to this debate is a response to a very frequently made argument here. And the frequently made argument is this: race is a social construct which maps poorly onto biological variables like genetic ancestry, right? There is a bad correlation between race, the social variable, and actual biological variables like genetic ancestry. Therefore, because race is a social construct and is not biological, we should not use it as a predictor of medical or biological outcomes. Our argument is this: we emphatically agree that race is a social construct. This is, inarguable. But this on its own is not always a reason to remove race as a predictor. The mere fact that race is a social construct does not inherently mean we should not use it as a predictor in clinical algorithms. Why? Because social constructs can have medical consequences. Race as a social construct can have medical consequences because structural racism has medical consequences, right? In some sense, that is what this entire talk has been about, right? In particular, structural racism makes it more likely that some race groups will have critical risk predictors mismeasured or missing. And there are myriad examples of this, right? And I've talked about several in this talk, right? Disparities in testing, disparities in diagnosis rates, medical records missing entirely. We wrote a review paper a year or two ago, which cites a whole bunch of work on this, right? So we know this. This is a very well-known fact. Structural racism means that there are different rates of missingness and mismeasurement across race groups. And here we focus on a particular critical risk predictor, family history. And why do we focus on family history? Two reasons. The first is that it is, a critical predictor in many clinical algorithms that seek to estimate patient risk, right? If you go in for a mammogram or an MRI, like, yes, the doctor is absolutely going to ask you if you have a family history of breast cancer. So that's the first reason. Family history really matters to predicting patient risk. But the other reason is that there is abundant evidence of mismeasurement of family history in a way that varies across race groups. We know from previous work that clinicians are less likely to ask non-white patients about family history, and that non-white patients have higher rates of unknown family history. So both on the patient side and the clinician side, there is reason to believe there is differential mismeasurement of this critical risk predictor. Okay. So we focus on family history and we study sort of its implications for whether we should use race in clinical risk prediction algorithms. The data set we use is what's called the Southern Community Cohort Study. This is a prospective study established in the early 2000s, goal being to study health and specifically cancer disparities. Recruitment was predominantly of community health centers in the southeastern United States. The cohort is predominantly Black, and we focus on cancer risk, and we study how colorectal cancer risk varies as a function of race and family history. And I'm just going to show you the main results. Take these numbers and graphs with a grain of salt, because again, this is preliminary work, but the story we've seen so far is pretty clear. Family history is highly predictive for white patients. Here on the x-axis, I'm showing you age. We plot results by age just because it's very strongly correlated with cancer risk in our data and in general. And on the y-axis, I'm plotting risk of colorectal cancer. I've broken it down by family history and no family history, and this is for white patients. And you can see that family history is very strongly predictive. The odds ratio is 1.8. It's highly statistically significant. But for Black patients, the story looks very different. Now the lines are on top of each other. The odds ratio is close to 1. Family history, while very predictive for white patients, is not predictive for Black patients. And this is totally consistent with the story of differential mismeasurement of family history across race groups. In the statistics literature and epidemiology literature, this would be referred to as regression dilution or regression attenuation. Specifically, if you do a regression of cancer risk on family history and family history is mismeasured, it's going to bias that coefficient in the regression towards 0. The intuition for this is just like, imagine the limiting case where family history is just randomly measured. Then the coefficient is going to be 0, right? Because it's just a random variable. If it's perfectly measured, then you're going to get the true coefficient. And so in between those two extremes, you sort of get this bias down towards 0. So in the presence of differential mismeasurement across race groups, you're going to get different sized coefficients of family history across race groups. The correct way to capture these different sized coefficients across race groups is by including race in the model, right? That's how you capture this differential mismeasurement. And so you can have an interaction term between family history and race, and that is indeed statistically significant in our data. And, we actually test this out, what would happen if we used a risk score with and without race. And basically what we find is that if you fit a risk predictor, which includes race, sort of interacted with other predictors, it increases the fraction of Black patients flagged as high risk. So it's actually more likely to rate Black patients as high risk of breast cancer, potentially enabling them to receive, higher rates of screening. So if anything, it makes the predictions more equitable. It does not harm performance. It seems to slightly improve performance, but those results are preliminary, so I'm not gonna highlight those. Okay, so to summarize the argument we are making here, the scrutiny of the use of race in clinical algorithms is absolutely essential. It's decades overdue. It's great that the community is having this debate. Much of the argument here has focused on how race is a social construct and a poor proxy for biological differences, and that is inarguably true. An implication is being drawn from that fact that therefore, race shouldn't be used to predict biological or medical outcomes. We argue, however, that race as a social construct should still sometimes be used to correct for differential mismeasurement and missing data. And we provide a case study of family history to illustrate that. All right, those are all the stories I have for you today. I've told you 2 stories about human bias, 1 story about algorithmic bias, both of them intimately linked to missing data, which is, my current intellectual obsession. And so very happy to chat more about any and all of these directions. Thank you so much.
Amazing. Thank you so much, Professor Pierson. Do we have any questions from the audience? That was a great time. If you could raise your hand using the Zoom functionality, otherwise I might not see you.
Yeah, can you call on people? I can't see anyone because I can't see them.
Ahmed, go for it.
Yeah, so thank you for the talk. It was really interesting. So just to the last point that you made around using race was important in the model for, I think it was breast cancer. I've also seen papers where they show that, like using race is negatively affected. So I wonder if there is like and I guess you've alluded to it in terms of missingness and how reflective is it of some other biases, but is there a kind of a framework or something that people can do to understand when it would be beneficial to use versus not? Because I imagine it's kind of a case-by-case basis.
Yeah, totally. And to be very clear on what, I'm certainly not saying always use race. It's always fine. I think there are definitely cases where we should not be using race at all because the empirical data is sketchy or because you really are trying to use it in a bad way as a biological proxy for something. So whatever. But I guess what we're saying is, in cases where, for example, you want to use it to correct for differential missingness and where there's sort of strong empirical evidence that it really does matter. And if anything, it reduces health disparities. That to me is a fairly compelling argument for considering including it. I would also point you to, I believe it is this paper, Hidden in Plain Sight, Reconsidering the Use of Race Correction in Clinical Algorithms. In general, there's been a lot of interesting opinion pieces written on this recently. I think this is quite a useful one, and they provide, I think, a 3-part criterion at the end. And I think what I'm not going to remember every single part of their 3-part criterion, but like one of them is like the strength of the empirical evidence. Another one is, does it, reduce or enhance health disparities? I think those are both good things to consider. And so, I don't think I'm quite ready to sort of propose like a step-by-step framework, but I do have pretty strong opinions about the fact that, race being a social construct is not on its own reason that it should not be included as predictor.
So, thank you.
Great, thanks, Ahmed. Tony.
I kind of stole my question. Pretty similar outlook, but I guess my question, slightly different, was I think it's pretty cool that you're talking about using race for trying to correct like family history if there's like good evidence of it. If you had like any other citations, or maybe we could reach out in like an email for like other forms of data types where like the race correction is like super backed by literature, that'd be super awesome. Because I think that's a common question that comes up in our Odyssey work. Like, what data can we take from like Odyssey and trust whether there was is there like a potential like racial difference in like how the data was collected versus in how like, is it necessarily neutral versus like, I guess. Yeah.
I guess the most relevant citations in this talk I would point you. So, okay, so this paper that we wrote, I think, honestly, I think the main benefit of that paper is it has a lot of great citations on data collection, not to knock my own work, but I think almost the value is more the links to other people's work. And they provide a lot of examples of cases with sort of differential missingness data. So I would take a look at that one. In the specific case of family history, here are 2 citations about how it's sort of differentially collected across race groups.
Thanks, that's super good to know.
Thanks, Tony. All right, we are rapidly approaching 2 p.m., but we'll try and squeeze in these last 2 questions. So Ali.
Hi, great talk. I just had a quick question, I guess, on this family history topic. Was there ever a analysis looking like at different, like how it stratifies by clinician? Because I'm curious, like there may be race-based differences in like the types of doctors patients see. Like maybe they're seeing more genetic doctors in like the white population, and they'll take a great family history. And that's also a marker of like socioeconomic status in that they have access to those doctors.
Yeah, that's super interesting. We haven't looked at the type of doctor they're seeing specifically, and I'll ask Anna about that. That's a good point. I mean, certainly there's previous literature in other contexts showing, for example, like race concordant doctors can lead to better outcomes, and so I think that's a very interesting question.
Great. All righty, and last one, Adrian, go for it.
There. Hi, Dr. Pierson. Thank you so much for your talk. So many interesting stories. It really did weave together so well. I'm wondering, as students, we talk about justice and trying to prevent our work from introducing more harms. And, we also talk about proxies a lot. And I'm wondering if you have any advice for us, any like pragmatic, practical, again, not you said you're not ready for frameworks, but any ways that we can kind of think through these proxies in the informatics domain, and how we can try to avoid reinscribing harms into the system through our data science?
Yeah, I mean, it's a broad question. I mean, I think certainly, one question I ask is like, yeah, is this tool sort of entrenching or ameliorating disparities? I ask questions like, in the specific case of proxy, I think one of my favorite pieces of writing on this is what's called the algorithmic bias playbook, which you can just download online. And that is, I think, a lot of sort of clear thinking and good examples on proxies in medicine, specifically sort of as outcome variables. And I think that's a pretty nice reference on this. And they actually do provide a framework of like step 1A, step 1B, and that is comforting. And so I think that's quite a good reference on this.
Much appreciated. Thank you so much.
Great. All righty. Well, thank you so much again, Professor Pierson, for this amazing talk. It was just really well done, and we all really appreciate it. So thank you for your time. And thank you to everyone else for attending. Have a great rest of your Monday.